welcome everyone to this session on update and perspectives in PCOS. I am Polimara Spritzer, endocrinology at Universidade Federal do Rio Grande do Sul, Porto Alegre, Brazil. And this is the female endocrinology meeting. This session is in partnership with Androgen Access and PCOS Society. So in addition to the attendees of the Endofeminina, also members of the Androgen Access and PCOS Society are present at this session. So welcome. And I'd now like to introduce Dr. Kathleen Hugger. Dr. Hugger is Professor of Obstetrics and Gynecology and Chief of Reproductive Endocrinology at the University of Rochester, New York. She is the current president of the Androgen Access and PCOS Society, and we'll say a few words about the society and introduce the speakers for these sessions. Please, Kathy.
Good morning to all, and thank you very much for the invitation for the Society to join this meeting, and I'm very pleased to represent the Society. As Dr. Spritzer has indicated, I'm the current president of the AE-PCOS Society, and this is our 20th year as this international society supporting and encouraging the best in science and education in androgen excess disorders. We preserve many of the abilities to allow us to have a forum of exchange of ideas in our meetings. We also have our annual meeting and our update meeting associated with Endocrine Society. We like to provide a platform for investigators to search for collaborators, as well as disseminate information, along with others in the patient arena as well, to provide an ability for all aspects of androgen excess disorders to be investigated and translated into the community at large. This is part of our ability to do that is to partner with other organizations such as the Endofeminina. So we're pleased to do that. We encourage membership, and I know many of you are members, and we would love to have more of you join our society. So with that, I would like to introduce our speakers for this session. Dr. Wichtel will begin our session. She is a tenured professor of pediatrics in the University of Pittsburgh Medical Center. She is the program director for the Pediatric Endocrinology Fellowship Program at UPMC in Pittsburgh, and shares the Differences in Sex Development Committee of the UPMC Children's Hospital of Pittsburgh. She is elected to the board of directors of the Pediatric Endocrine Society and is a former past president of this organization, the Androgen Access PCOS Society. She's an associate editor for the Journal of the Endocrine Society as well. Additionally, Dr. Dokras will be joining us. Dr. Dokras is the director of the Penn Polycystic Ovary Syndrome Center. She's the medical director of the Reproductive Surgical Facility and professor of obstetrics and gynecology at the Hospital of the University of Pennsylvania. She is also the current executive director of the Women's Health Center for Clinical Innovation. Dr. Dokras shares a love of PCOS with all of us and has been the associate executive director of the Androgen Access PCOS Society currently, and a previous past president. And finally, Dr. Venki, Dr. Esther Venki, is a professor of obstetrics and gynecology at the Department of Clinical and Molecular Medicine in Trondheim, Norway. She is the initiator and chair of the Nordic PCOS Network and head of the research group Women's Health and PCOS at the Institute for Laboratory Medicine. Children and Women's Health at the Department of Obstetrics and Gynecology, St. Olav's Hospital, Trondheim, Norway, and is also a member of our Androgen Excess PCOS Society. So thank you all again for joining us, and I encourage you to stay interested and continue your work with androgen excess and PCOS disorders, and we look forward to the session.
First, I'm Selma Witchell. I'm a pediatric endocrinologist at the University of Pittsburgh in Pittsburgh, Pennsylvania. I would like to take this opportunity to thank the organizers and AEPCOS for inviting me to be part of this update meeting, at which time I'll talk about the challenges in the evaluation of PCOS in the adolescent girl, or pubertal commencement of ovarian dysfunction. I would like to make a shout out to my colleagues Sharon Oberfield, Alexia Pina, Alina Teed, Tony Plant, Dave Abbott, and Dan Domestic for thinking and talking with me over the years about this complex disorder. I have no financial or other conflicts of interest. Today we'll learn diagnostic features and criteria for PCOS in adult women and adolescent girls and recognize the differences. We will appreciate the interactions between the multiple factors involved in the pathophysiology of PCOS. And we will learn PCOS features deemed to be important by affected adolescent girls. As we all know, PCOS is a common disorder affecting 8 to 13% of women, depending on the diagnostic criteria, and it involves multiple organ systems. The ovary is in the middle of this picture because it seems to be central to the process, but once the process gets going, it becomes a vicious cycle. This slide depicts a more updated pathophysiology of PCOS, with the picture on the right depicting the hypothalamic pituitary ovarian axis and including the role of AMH in the pathogenesis of PCOS. The picture on the left reminds us that in addition to reproductive dysfunction, PCOS is a multi-system disorder with features including anxiety, depression, and insulin resistance. In some ways, we are only seeing the tip of the iceberg, focusing on acne, infertility, hirsutism, male pattern baldness, oligomenorrhea, and insulin resistance. Lurking beneath the surface are other comorbidities such as fatty liver disease, sleep apnea, impaired glucose tolerance, dyslipidemia, impaired quality of life, depression, and obesity. Approximately 10 or so years ago, our colleagues, including myself, started discussing the need to develop specific criteria for PCOS both in adult women and in adolescents. This began with the 2015 criteria for diagnosis of PCOS in adolescents, followed by the International Consortium published in 2017, and culminating in the International Evidence-Based Guideline published in 2018. From these, we have learned that Rotterdam criteria are the most firmly grounded as the best evidence for adult women. Just to review, the Rotterdam criteria require two of the following: oligo or anovulation, clinical and or biochemical hyperandrogenism, or polycystic ovary morphology. Most importantly, other disorders need to be excluded. On the bottom of the slide are the 4 phenotypes in which PCOS can be categorized. Just to remind everybody that non-classic CAH and PCOS have overlapping features. They affect adult and young women. Hirsutism, irregular menses, polycystic ovary syndromes, acne, infertility, and hyperandrogenism can occur in both disorders. Insulin resistance tends to be more common in PCOS, and clitoromegaly tends to be more common in non-classic CAH. So importantly, PCOS is a diagnosis of exclusion. We now move to the adolescent girl. Adolescent girls can have irregular menses. They typically have acne, mildly elevated androgen concentrations, and they have multifollicular ovaries on ultrasound. So how can we apply the Rotterdam criteria to adolescent girls when adolescent girls have many of the features as part of the normal pubertal transition? So what are the appropriate diagnostic criteria for PCOS in adolescent girls? Here is our conundrum. adolescent girls have irregular menses, hyperandrogenism, and we need to exclude other disorders. We need to balance between overdiagnosis of PCOS and labeling girls who ultimately will not evolve to have PCOS and will be normal, to the possibility for a missed opportunity to diagnose and intervene in young ladies who are lost to follow-up and end up in this situation of the blind man and the elephant, where they seek care for hirsutism or an ovarian disorder or irregular menses from different healthcare professionals who don't consult with each other. These young ladies may see 2, 3, or more physicians until the diagnosis of PCOS is finally made. So let's parse out some of the diagnostic criteria related to adolescence. By 2.5 years post-menarche, menses generally occur every 21 to 40 days. Now, it's about 12 years ago, Rick LeGros did a study looking at a small number of healthy girls in central Pennsylvania and followed them longitudinally. By 3 years post-menarche, 90% had at least 10 menses per year. Facial acne is very common in adolescence. Severe acne is uncommon and may be associated with a hyperandrogenic endocrine disorder and warrants further evaluation. Hirsutism is defined as excess terminal hair growth in male typical body areas. Importantly, patients may shave or use cosmetic treatments right before their evaluation, often the night before their visits. Hirsutism reflects the interaction between circulating androgen concentrations, local androgen concentrations, and the sensitivity of the hair follicle to androgens. The severity of the hirsutism does not correlate well with circulating androgen concentrations. Importantly, hair growth is comparable in unselected white and black women. This slide depicts the modified Fairman-Gallwey scoring system. There are 9 body areas and 4 scores for each area. This provides a semi-objective measure to something that's very subjective. It's important to remember that there is less hair per unit skin area in women from China, Japan, and Thailand. Cut points typically used for the modified Fairman-Gallwey scoring system are 4 to 6 for white and black women, but these cut points still remain somewhat controversial. And again, importantly, patients may use cosmetic treatments before evaluation, so one must ask if something has been used the night before or in the recent past prior to the office visit. High-quality testosterone assays should be used to assess for biochemical hyperandrogenism. One can use calculated free testosterone, available testosterone, and/or free androgen index. Direct free testosterone assays are not adequately sensitive, accurate, or reproducible and should be avoided. Androstenedione and DHEAS can be useful. When hormone levels are extremely elevated, there's a need to assess for other causes of androgen excess, such as androgen-secreting tumors. Reliable assessment for hyperandrogenism is impossible in women on oral contraceptives. I put this slide in to remind us that androgens are needed in the ovary in just the right amount. They help promote follicular initiation, maintain follicle health, but in excess reduce ovulation and impair oocyte development. So similar to the fairy tale of Goldilocks and the 3 bears, androgens are needed in just the right amount at just the right time in the ovary. This slide depicts the multiple pathways for androgen synthesis. In the middle is the classic hypothalamic pituitary adrenal axis. On the top right is the alternative backdoor pathway, which is probably most relevant for prenatal virilization of the affected girl with congenital adrenal hyperplasia. And on the bottom are the pathways for the 11 oxoandrogens, which are more recently studied and evaluated for their roles in normal as well as abnormal androgen actions. One question relevant for the adolescent girl is, can ovarian morphology be used for the diagnosis of PCOS? Polycystic ovary morphology has been defined in adult women based on follicle number per ovary and ovarian volume, but can this be used for adolescent girls? We have an answer from Ethel Kodner's study looking at polycystic ovary morphology in 17 adolescent girls followed for over 3 years with annual pelvic exams. The cartoon depicts the results of the study. 7 girls had normal morphology at all times. 9 girls had polycystic ovary morphology at least once, and only 1 girl had abnormal morphology at all time points. Polycystic ovary morphology was associated with lower FSH concentrations, but there was no association with decreased ovulation, irregular menses, or metabolic disturbances. So, summarizing from the guidelines, ultrasound should not be used for the diagnosis of PCOS in those with a gynecologic age less than 8 years of age due to the high incidence of multifollicular ovaries in this life stage. What about AMH concentrations? In the middle is a diagram depicting normal concentrations longitudinally in healthy girls and adolescents as a function of age. And one sees there's blue lines, red lines, and black lines indicating individual girls over time, suggesting that each girl has her own set point. This makes it very difficult to establish a definitive normal range for AMH levels in this age group. So AMH is a dimeric glycoprotein membrane of the TGF-beta family that is secreted by granulosa cells. It indicates follicle number per ovary in polycystic ovary morphology and reflects ovarian reserve. Its highest levels are expressed in the preantral and small antral follicles, and its levels decreases following selection of the dominant follicle, following increased FSH action to increase aromatase expression and estradiol. These lead to decreased AMH expression. So again, summarizing the guidelines, AMH levels should not yet be used as an alternative to the detection of polycystic ovary morphology or as a single test in the diagnosis of PCOS. And this is because assays are yet to be standardized and normative ranges need to be defined. So AMH may ultimately be used, but it's not yet ready for prime time for clinical use. Insulin resistance, hyperinsulinemia, and obesity are common features in women with PCOS. Women with PCOS have an increased risk to develop type 2 diabetes, cardiovascular disease, and dyslipidemia. No single diagnostic feature of PCOS is independently associated with impaired insulin action, excessive insulin secretion, or obesity. Recently, bidirectional Mendelian randomization showed that increasing BMI promotes PCOS, whereas PCOS in and of itself does not intrinsically increase BMI. Importantly, insulin resistance, hyperinsulinemia, and obesity cannot be used as diagnostic criteria for PCOS in adolescents or adult women. As we all know, PCOS is familial. Hereditability is approximately 70%. Based on GWAS studies, at least 26 loci are associated with PCOS, and multiple loci are shared between the Chinese and European GWAS, indicating that PCOS is likely an ancient disease. Daughters of women with PCOS have a 5-fold increased risk to develop PCOS. Again, this is a familial disorder. Here we go, back to the conundrum of diagnosing PCOS in adolescents. One can say a young lady does not have PCOS, or she fulfills the criteria for PCOS. But what about those girls who have some features but don't yet fulfill the diagnostic criteria? They can be labeled or considered as being at risk for PCOS. So to summarize the guidelines and looking at defining irregular menses are normal in the first year as part of the pubertal transition. From 1 to 3 years post-menarche, menses should be between 21 and 45 days. From 3 years post-menarche until the perimenopause, menses should be between 21 and 35 days, or at least 8 cycles per year. Following that first gynecologic year, if a menstrual cycle is greater than 90 days for any one cycle, that is abnormal. Primary amenorrhea by age 15 years or greater than 3 years post-elarchy is also abnormal. Abnormal menses should be further evaluated, with PCOS being one of the diagnostic possibilities. For adolescent girls with features of PCOS who do not meet the diagnostic criteria, this category or labeling of increased risk can be used, and what this says is these young ladies can be treated for their symptoms and need to be followed for outcome. When PCOS is one of the diagnostic considerations, this needs to be discussed with the young lady and her family regarding the potential diagnosis and its implications. This slide shows data from the RAIN study, a prospective cohort study from Western Australia. This includes 227 girls in the final analysis. So these are girls followed longitudinally. The green line indicates girls who do not have PCOS. The yellow line indicates girls who have oligoanovulation and polycystic ovary morphology. Blue indicates girls who have hyperandrogenism and polycystic ovary morphology. And the red indicates the girls who have oligoanovulation and hyperandrogenism and are considered to have polycystic ovary syndrome. So of this group, 37% participants, or 16%, were diagnosed with PCOS using the updated 2018 criteria. As you can see, the BMI in the affected girls was greater than the other girls from age 14 years. So only those with a phenotype fulfilling the updated criteria demonstrated higher long-term BMI gains. In summarizing, the prevalence of PCOS was comparable in this group to the prevalence reported in adult women. Adolescents diagnosed with PCOS showed the greatest weight gain over time. These data indicate that ovarian ultrasound can be admitted during the evaluation of PCOS in adolescents, so one does not need to do ovarian ultrasounds. Girls considered to be at risk for PCOS should be reassessed in later adolescence and adulthood. These data suggest that one can target high-risk adolescents for early lifestyle intervention and perhaps provide an effective intervention to prevent the development of PCOS. Goals of treatment, as we all know, are to regularize menses, decrease signs and symptoms of androgen excess, improve self-esteem, as well as decreasing risk for other comorbidities. Oral contraceptive preparations have similar efficacy in preventing hirsutism. One needs to think about risk for venothrombotic and embolic phenomena in choosing the oral contraceptive, or whether OCPs are an appropriate choice. Lower doses, 20 to 30 micrograms of ethinyl estradiol, are equivalent to be considered and balanced according to efficacy, metabolic risks, and side effects. PCOS-specific risk factors such as high BMI, dyslipidemia, hyperglycemia, and hypertension should be considered. So again, back to the guidelines and summarizing, oral contraceptives can be considered in girls who clearly have a diagnosis of PCOS, and even those who are at risk for the management of clinical hyperandrogenism and irregular menses. Metformin can be used in those that have high metabolic risk, including those with high diabetes risk factors, impaired glucose tolerance. One needs to discuss with families the adverse GI effects that are generally dose-dependent and self-limited. One starts at a low dose, gradually increasing the dose. Metformin use appears to be safe for long-term use. Its use is generally off-label, and we should discuss with families that this is an off-label but evidence-based medication. So clinical practice points are to consider individual personal preferences, characteristics, and values in choosing pharmacologic treatment. One needs to consider benefits, adverse effects, and contraindications. And as I mentioned, metformin and other medications are off-label, but in this instance, off-label is evidence-based. Recently, Alexia Pina has published data looking at what features of PCOS are important to adolescent girls, as summarized on this table. So their irregular menses, their difficulty with losing weight or problems gaining too much weight, excess hair, skin findings, and moods are important features to them. When asked what important topics are relevant for future research, these young ladies said knowledge being power about PCOS, concerns about their hair, their weight, their fertility, risk for diabetes, insulin resistance, support systems, and quality of life. So PCOS begins around the same time as gonadotrophy. Both reflect functional changes in the neuroendocrine axis regulating the ovary. So this raises the question, is pubertal development going on normally, and something about PCOS sort of hijacks normal pubertal development? Or does puberty merely activate an imprinted organizational susceptibility to develop PCOS? To get some clues to the answer to this question, we can look at testosterone treatment in female to male transgender patients. In these patients, testosterone decreases LH concentrations, leading to amenorrhea, and we all have had uncertainties regarding ovarian morphology and the potential for future fertility in these patients. Yet, upon discontinuation of testosterone, some patients resume fairly normal HPO axis activity, actually fairly quickly, often within 3 to 12 months. Pregnancies, successful oocyte retrieval, and live births have been reported. So testosterone treatment to post-pubertal, otherwise normal females does not permanently imprint or activate neuroendocrine mechanisms controlling GnRH and gonadotropin secretion. Rather, this suggests that ongoing androgen exposure appears to be important to induce and maintain a PCOS phenotype. So coming back, there's androgen exposure at multiple stages through the life cycle, from pregnancy, in utero with evidence of longer androgenital differences in newborns, childhood manifestations. So let's think about androgen exposure and try to identify the phenotypes at different ages. To summarize, the overlap between normal pubertal development and the characteristics features of PCOS confound diagnosis. Diagnosis requires exclusion of other disorders associated with irregular menses and hyperandrogenism. Persistence of oligomenorrhea for at least 2 years and the presence of other clinical features of androgen excess warrants consideration of the diagnosis of PCOS. Deferred diagnostic labeling and frequent longitudinal reevaluations of girls considered to be at risk for PCOS are important to avoid overdiagnosis and unnecessarily treatment of otherwise healthy girls. We treat to alleviate the current symptoms and decrease the risk for associated comorbidities. Although obesity, insulin resistance, and hyperinsulinemia are common findings in adolescents with hyperandrogenism, these features should not be used to diagnose PCOS among adolescent girls. Prospective, longitudinal studies are needed to understand the natural history for girls considered to be at risk for PCOS. Key gaps in patient satisfaction have been demonstrated. Health professionals should be armed with awareness of the impact of PCOS on quality of life and should capture patient priorities to deliver meaningful outcomes when partnering with women with PCOS. We need to be aware of the high prevalence of moderate to severe anxiety and depressive symptoms in adults and a likely increased presence in adolescent girls as well. So what are we to do? Ideally, we need to identify girls at risk for PCOS early. The diagnosis of PCOS in a woman should prompt evaluation of other family members due to their increased risk to develop type 2 diabetes and metabolic syndrome. Women with PCOS serve as probands, early warning signals, or the canaries in the cave for their extended family members. The evidence-based guidelines recommend women with PCOS adopt healthy lifestyles for themselves, promote healthy lifestyles for their extended families to ensure the practice of healthy habits from early childhood for their children and their grandchildren. Important research questions for the future are to characterize genetic and epigenetic factors associated with PCOS, ascertain the molecular signatures associated with the transmission of PCOS-like phenotype, delineate the factors that promote the development of PCOS, identify novel predictive and diagnostic biomarkers that will enable early identification of the daughters at risk to develop PCOS, and develop novel strategies to prevent the development of PCOS. So in summary, this is the PCOS phenotype with different manifestations at different ages and multiple factors continuing to the development in the phenotype. Our task is to find the factors that enable improvement in diagnosis and early recognition. And with that, I thank you for your attention and thank you for inviting me.
So, dear organizing committee, dear friends, colleagues, thank you very much for inviting me to this session. And I'm going to talk about the impact of metformin on maternal and long-term offspring outcomes in women with PCOS. I will mainly focus on the molecular mechanism of metformin, the rationale for using metformin in pregnancy, and the evidence for this practice. And I will also talk about how it affects the mother and the child. You all know metformin being a drug used mostly in type 2 diabetes the last 60 years and in pregnancy since the late 70s. What is more interesting about why metformin came to be used in pregnancy? We know that maternal insulin resistance and hyperglycemia is closely correlated to miscarriage, congenital malformations, hypertension, intrauterine death, macrosomic fetus, and birth trauma. And metformin, being a cheap, easily stored and administered drug with no hypoglycemia, it's non-toxic and have relatively limited side effects, it seemed to be a great idea to try to treat maternal insulin resistance and hypoglycemia with metformin in order to reduce these complications. Now, the dosage, the optimal dosage used in pregnancy is not settled. Different studies report doses from 500 to 2,500 milligrams daily. What we know is that the concentration during pregnancy is decreased compared to the non-pregnant state. And this is mostly because of increased renal clearance. Metformin passes also the placenta, and similar concentrations are found in the umbilical cord blood as in maternal circulation. Metformin is taken up to the cell by the OCT1 and OCT2, and in the placental cells OCT3. Now, in high concentrations, supraphysiological concentration, metformin inhibits the mitochondrial respiratory chain complex, resulting in reduced cellular respiration and reduced cellular energy state, leading to increased ADP-ATP ratio, which activates the AMPK. And AMPK is one of the central mechanisms by which metformin works. And as AMPK is activated, it switches the cells from an anabolic to a catabolic state, leading to reduced glucose, lipid, and protein synthesis, reduced cell growth, and increased fatty acid oxidation and glucose uptake. So, who are treated with metformin? The largest group treated with metformin are those women with gestational diabetes. And in many countries, metformin alone or combined with insulin is the first-line therapy for gestational diabetes. Another group are women with obesity. And in those women, it is to prevent excessive gestational weight gain, fetal macrosomia, and gestational diabetes. I will focus mostly on women with polycystic ovary syndrome, and in these women, the idea was to prevent or reduce miscarriage, gestational diabetes, preeclampsia, and preterm delivery. Now, we have known for almost 2 decades that in women with PCOS, there is a higher prevalence of almost all pregnancy complications. This knowledge is based on large population-based cohort studies and meta-analysis. The risk for this increased complication rate depends, of course, on the maternal BMI, socioeconomic factors, ethnicity, and probably also on the PCOS phenotype. Now, the last study is a large Swedish nationwide population-based cohort study, which comprised almost 700 women with singleton pregnancies. The authors could link the patient registry, death registry, and drug registry, and they compared women with known PCOS to women without known PCOS, and they also looked at the prescription of metformin. A weakness of this study is that only 2% of the women were identified as PCOS. Nevertheless, they report very much as the former studies that both cesarean section preeclampsia and gestational diabetes are increased among women with PCOS. And this remains significant also after adjustment for BMI and socioeconomic factors. My former PhD student Tone Løvvik has performed an individually pooled data analysis of 3 randomized control studies on pregnant women with PCOS. It was almost 800 women, and these women were included from 2000 to 2017 in Norway, Sweden, and Iceland. They had, of course, PCOS. They were included in the first trimester of pregnancy and had 1 single non-viable fetus. The women were randomized to metformin, 2 grams daily, or placebo, and they all received diet and lifestyle advice. The maternal age was 29 years, and maternal BMI at study entry was 28. So it was overweight, average overweight, but not obese population. The results from these meta-analysis was that metformin reduced late miscarriages and preterm births in women with PCOS, and this was significant. What was very much surprising was that metformin had no effect on the incidence of gestational diabetes, even though metformin reduced gestational weight gain compared to those who received metformin. And metformin had no effect on preeclampsia. This finding that metformin had no effect on gestational diabetes made me search for other randomized control studies which compared metformin to placebo in high-risk populations. And I found 10 studies in all to more than 2,500 participants. And these were studies on PCOS, overweight and obesity, and impaired glucose tolerance. And in these 3 studies, metformin had no effect on the incidence of gestational diabetes and no effect on the time point at the diagnosis of this diabetes, did not affect fasting or 2-hour glucose, and had no effect on additional insulin need. And also in these studies, the gestational weight gain were lower in the metformin. Now, to try to understand why metformin decreased preterm deliveries and late miscarriages, we looked at the androgen levels in these pregnancies. And here you can see the gray is the normal healthy pregnancies, and these red and blue are the PCOS pregnancies. And we can see that women with PCOS through pregnancy have significantly higher testosterone levels and free testosterone index. Now the blue line is those who receive metformin, and the red line the placebo group. And we see a slight decrease in the metformin group, but this did not reach statistical significance, not in testosterone and not in free testosterone index. However, normal weight and overweight women, metformin had an androgen decreasing effect, but not in the entire population. So we also looked at cytokine profiles. It was Ida Stokkeland, PhD student of mine, who created this figure explaining simpler, very complex statistical analysis. Here we can see the green line is the population of normal pregnant women. We see that there is a cytokine activation in the first trimester, then it's a lower activity in the second, and again a higher activity in the third trimester. And in women with PCOS in the blue line, we see that they have all in all higher immune mobilization, higher cytokine activity, but they are following the same pattern as normal pregnant women. She also looked at normoandrogenic PCOS women, the blue line, and hyperandrogenic PCOS women, the red line. And also here we can see that those with hyperandrogen phenotype had much higher immune mobilization, cytokine activity through the entire pregnancy. And not only inflammatory cytokines were activated, but also chemokines, growth factors, and anti-inflammatory cytokines. Now, what evidence do we have to treat women with PCOS in pregnancy with metformin? Now, metformin did not prevent gestational diabetes and had no effect on glucose homeostasis. It had no effect on preeclampsia, but women in the metformin group gained less weight in pregnancy, and they had significantly lower rate of late miscarriages and preterm birth. So let's have a look at the children born to mothers with PCOS. How are they doing? Here I summarize very shortly the former studies that looked at children at birth. And it is reported that children born to mothers with PCOS have a higher risk for preterm, being born preterm, high risk for having a large for gestational age and small for gestational age. During childhood, they have higher BMI and more central adiposity, and they have also subtle negative cardiovascular markers, and the girls have higher levels of testosterone. In the peripubertal period, the data are diverging according to ethnicity. Some studies report central adiposity, hirsutis, and testosterone in girls, while in boys they report higher BMI, more central adiposity, and insulin resistance. When reaching adulthood, those born to women with PCOS have increased endocrine, metabolic, psychologic, and respiratory disorders. Those mothers with PCOS and obesity have an increased risk in their children to have attention deficit disorders, autistic spectrum disorders, and somewhat reduced cognitive function. Now, how does metformin affect the human offspring? What do we know about that? We know that there is no evidence of any association between metformin and congenital anomalies in humans based on almost 2 million births from 11 European registries. But metformin exposure do affect the pancreatic beta cells. And the pancreatic beta cells differentiate during the first trimester and proliferate during the second and third trimester. And if the mother uses metformin during pregnancy, both immature and mature beta cells are exposed to metformin. Now, early in pregnancy, the embryonic cells have very little OCT expressed, and they have fewer and immature mitochondria, so the metformin does not reach into them. But later in pregnancy, the anti-growth effects of metformin on the pancreatic cells results on smaller beta cell mass during the development. These studies are based on mostly animal studies. And it is underlined that metformin may protect the beta cells when the environment is metabolically challenged by high fatty acid stress or hyperglycemia. But when there is no metabolic challenge, the proliferation of beta cells may be suppressed by metformin. Recently, Lin Nguyen reported on metformin also in human fetal cells. And they found that in normoglycemic environments, metformin impaired the development and function of human fetal beta cells. And this may result in beta cell toxicity with reduced capacity to withstand metabolic challenges later in life. We performed also another individually pooled data analysis from the 3 studies we have on pregnant women with PCOS, and looked at the neonates and the anthropometrics of the neonates. And it was a medical student, Guru Wilson, and the postdoc, Melanie Simpson. And to look at the PCOS effect, we compared those in the placebo group to a reference population Z-score. And we found that children or newborn to women with PCOS had similar birth weight and similar head circumference, but were shorter at birth compared to a Z-score that was adjusted to gender and gestational age. So in other words, these babies had a higher BMI and were fatter. To look at the metformin effect, we compared those in the placebo group versus those in the metformin group, and we found that the babies had similar birth weight, similar birth length, but those in the metformin group had larger head circumference. Liv Hanem, also a PhD student of mine, followed up the children from the 2 first studies at 4 and at 8 years of age. And she found that, now you can see here the red line, that is the Z-score of a reference population. The black line are those in the metformin group, and the dotted line in the placebo group. She found that the length of the babies were quite similar to those. It was quite similar to those in the reference population, both the metformin and placebo-exposed children, until they were 4 years old. The weight. You can see here that the placebo group follows fairly the same weight as the reference population, while those exposed to metformin have a catch-up growth until 6 months of age and then have a higher weight until 4 years of age. And of course this resulted in a higher BMI of those in the metformin group. So metformin exposed children had a higher weight, similar height, and a higher BMI at 4 years of age. We had also a clinical follow-up at an average 8 years of age, and we found that those in the metformin group were still significantly more overweight compared to those in the placebo group. But also those in the placebo group started to be a little bit more, have a little bit higher BMI compared to the reference population, but this was not significant. And two-thirds of those children who were overweight at 8 years of age were also overweight at 4 years of age. So these children had increased cardiometabolic risks in those in the metformin group. They had higher BMI, more central adiposity, and there were more obese children in the metformin group. And the obesity and overweight were more metabolically abnormal. Here is a figure that shows the correlation between maternal pre-pregnancy BMI and offspring BMI Z-score. The blue line shows the placebo group, and it shows that the higher the maternal pre-pregnancy BMI, the higher is the BMI Z-score at follow-up. The red line shows the metformin group, and this line is steeper, showing that those who are exposed to metformin in utero seems to be more vulnerable to be born into an obesitogenic environment. So could this be explained by the beta cell toxicity? Probably, yes. We looked also at the cognitive development of these children. Unfortunately, it was only a subgroup who participated in this follow-up, but we found that the full-scale EQ score was 100 in both the metformin and placebo groups, which is the mean, the average for the normal reference population. So we conclude that PCOS offspring had similar IQ as the reference population, and we found no difference between the metformin and placebo groups. So let me come with some conclusions. Mothers with PCOS have more often complicated pregnancies and complications in pregnancy. And metformin in pregnancy reduces weight gain of these mothers, reduces the number of infections during pregnancy, reduces preterm deliveries and late miscarriages. It mobilizes the immune system. It has no effect on gestational diabetes or preeclampsia or androgen levels. The offspring born to mothers with PCOS have altered anthropometrics, and those exposed to metformin have increased head circumference at birth, have higher BMI, and more central obesity at the age of 8 years, and there are also more obese children at 8 years of age. And metformin did not seem to have any effect on the cognitive function, but this was a small study. So this is what I had to tell you about this topic. Thank you very much, and greetings from an icy Trondheim. Thank you very much.
Thank you so much for inviting me to be part of this AEPCOS symposium today. And I'm going to talk to you about cardiovascular disease risk in polycystic ovary syndrome. These are my disclosures, which include some of the journals that I am on the editorial board, as well as my funding from the National Institute of Health. And our learning objectives today are going to include reviewing cardiometabolic risk associated with PCOS. And I have split this into 3 parts. One, we're going to talk about the biomarkers. Second, the subclinical atherosclerosis. And finally, the evidence for cardiovascular disease events. And then we will conclude by talking about some of the screening algorithms specifically for cardiovascular disease prevention. So, most of you in the audience, or I would think all of you, are familiar with the Rotterdam criteria, but I wanted to start with this just to review that the way the Rotterdam criteria are laid out currently, where we include 2 out of 3 for the diagnosis of PCOS, results in significant heterogeneity in our population that's included in studies. And by that, what I mean is there are groups of women that have all 3 criteria, as you can see in the center over here, where type A has all, type B has the hyperandrogenic and the oligoovulation. Type C, which is less common, have regular menses with hyperandrogenism and the polycystic appearing ovaries. And then the type D is the non-hyperandrogenic phenotype. And I wanted to bring this up right at the beginning because we believe that the cardiometabolic risk is primarily in the hyperandrogenic phenotype. And wherever that data is available, I will try and point that out as we go through this presentation. The second aspect that I wanted to talk about is the change that occurs in some of the features of PCOS with age and specifically towards the menopause. And this is one of many studies that is now showing us that as women with PCOS get older, the testosterone numbers will decrease, as well as the ovarian volumes will decrease. In addition, a number of these patients will start having regular menses and ovulatory cycles. So the reproductive phenotype of PCOS is known to improve as one gets closer to menopause. And the question again for today is, what happens to the cardiometabolic profile during this time period? And wherever we have information in the literature, I'm going to try and point that out as well. So what we're going to talk about then is PCOS and more specifically the role of hyperandrogenism and how that is going to drive cardiometabolic risk. Number 2, how it's going to, what is the data for subclinical atherosclerosis? And then number 3, what is the risk of actual cardiovascular disease events? So starting with the first one, the biomarkers and the risk factors that are traditionally recognized as resulting in a higher risk of cardiovascular disease with age are obesity, impaired glucose tolerance and type 2 diabetes, dyslipidemia, hypertension, metabolic syndrome, and inflammatory markers. And as you can see in this diagram here, the visceral adiposity, which is common in PCOS, results both in an increase in low-grade markers of low-grade inflammation, as well as insulin resistance. Both of these can drive hyperandrogenism through the ovary and set up a vicious cycle that can increase the risk for a number of these biomarkers. So it's pretty clear that obesity levels are increased in PCOS, and here is a meta-analysis which shows us that the odds ratio is about 2.7. It has been shown to be higher in the white population compared to Asians. Similar rates if you look at NIH versus Rotterdam criteria. And what we do recognize is that central obesity is significantly higher in PCOS as compared to peripheral obesity. Unfortunately, obesity starts at a young age. And there's data suggesting that this starts in adolescence. Here is one study from Australia, where you can see that amongst women with PCOS, the BMI, amongst teenagers with PCOS, the BMI was 29.4, whereas the mean BMI in the control group was 22.4. And when you look at the prevalence of obesity in these very young women, 50% for PCOS versus 6% in controls. There's lesser and fewer data tracking this through the perimenopause and beyond. And here is a very recent systematic review that has been published looking at a number of cardiometabolic outcomes, but they do not show significant differences in weight between women with PCOS and controls as they are tracked through the third and the fourth decade of life. Significant limitations in the studies that are included, including small sample size and the definition of PCOS varying between studies. But again, cross-sectional studies, as I have shown you, definitely support higher prevalences of both overweight and obesity in this population. Women with PCOS have a higher prevalence of impaired glucose tolerance with an odds ratio of about 3.2. The prevalence varies, though, depending on the population. So much lower in the East Asian countries, down at 6%, much higher in the US, as high as 35%. And this has been shown through BMI match studies, even in the lean population. And there are mixed results in adolescents, again, given the small sample sizes and the difficulty with the precise definition in adolescents. With type 2 diabetes, which is definitely associated with significant morbidity and mortality, the odds ratio is 2.8. Prevalence, again, as you see here, can be as low as 2 to 10%, but much higher than a control population, keeping in mind these are reproductive age young women. Now, the caveat here is that the BMI match studies do not show significant differences in the risk of diabetes. But when you look at population-based studies, longitudinal studies, there's definitely an increased risk. The hyperandrogenic phenotype seems to drive this risk. Mixed data for adolescents and very limited data in the postmenopausal women. And I wanted to pull out this particular study, which is the General Practice Research Database, which uses this database in the UK, where they looked at the hazard ratio in the reproductive age group. And these are all women with PCOS. And what's striking is that age-related within this age group, even the younger women had a high hazard ratio for type 2 diabetes. Going on to dyslipidemia. So the dyslipidemia profile that's commonly seen in PCOS is a low HDL-C level and high triglycerides and high LDL-C. One might ask that what is the significance of some of these findings, because the differences, although they may be statistically significant, may not be as clinically relevant because they're just small changes that have been documented. And again, in the adolescent population, these are smaller studies and fewer studies. In general, when one looks at BMI, the results are mixed, where their significance may remain or not. And in the hyperandrogenic phenotype is where we see most of the significant changes. Longitudinal studies also show mixed results. So given this data, we asked a few questions within our group to say, what is the function of some of these cholesterol molecules, and is that impaired? So on the left here, you can see that HDL cholesterol plays a really important role in moving cholesterol from the arterial wall in the macrophages out into the circulation and excretion through bile. And this process is known as the reverse cholesterol transport. And it has been shown that when the cholesterol transport is impaired, there is a high risk of coronary artery disease. So we conducted a study looking at women with PCOS and controls, and we found that the HDL-C cholesterol, and in fact most of the lipid profile, was very similar between the two groups. But when we looked at the cholesterol efflux capacity, this ability to transport cholesterol from the arterial wall and excrete it, it was impaired in PCOS such that it was about 11% lower as compared to the control population. We also looked at the LDL particles. So if you recall, the numbers were same in both groups, but when you actually look at these subclass particles with NMR spectroscopy, then the differences in VLDL, LDL, as well as HDL are significant, and they show an atherogenic lipid profile, again suggesting that there are early signs of dyslipidemia, which may not be picked up on a traditional lipid profile, but can be picked up by some of these sophisticated methods for measurement. Moving on to hypertension, there's data again suggesting, as seen here in the meta-analysis, of an odds ratio of about 1.75. Limited data in adolescents, but longitudinal studies support higher rates of hypertension in the PCOS population. And then when we look at inflammatory markers, I have listed, there's a long list of markers that have been studied in PCOS. The ones that I've put in bold are the ones that are more consistently elevated and controlling for factors such as obesity. None of these are ready for prime time. We're not really using these as screening tools currently, except maybe for HSCRP that is used in risk stratification by cardiologists. But it is pretty clear that hyperandrogenism combined with obesity and maybe the nutritional input of some of our dietary factors can modulate inflammation, and that could then in turn affect both the reproductive phenotype of PCOS as well as the metabolic phenotype of PCOS. So how do we put all of these biomarkers together? One of the ways of looking at it is to look at the risk of metabolic syndrome, because as you might recall, this includes 3 out of 5 factors: obesity, or waist circumference, hypertension, lipid profile, as well as glucose tolerance. And when you look at a composite index, there's compelling evidence to say that both adults have a higher risk as well as adolescents. So now when you look at not just one factor by itself, but as a composite score, even our young patients seem to have a higher risk of metabolic syndrome. And this is borne out when one looks at BMI match studies as well as the hyperandrogenic phenotype. I included this study because it has data specifically from Brazil. We had conducted a study looking at 5 different groups of patients in the US, India, Brazil, Finland, and Norway, and then looked at the prevalence of metabolic syndrome amongst these groups to try and understand if there are any geographic or ethnic variations. All of these groups are higher than the background rate within each country, but the components of metabolic syndrome vary in each of it. So for example, in the US population, especially in women who are Black, there's a higher prevalence of obesity and hypertension. When we looked at the Brazilian population, there was a higher prevalence of the triglycerides being elevated and the HDL being low. So again, being aware of which component of metabolic syndrome is going to be abnormal within your specific patient population becomes important in order to target the therapeutic interventions. And I added the separate slide looking at the long-term cardiometabolic risk because we talked in the very beginning that the reproductive phenotype might improve with age. The periods get regular, androgens might decrease, but the question we're really trying to ask is what is the long-term cardiometabolic risk? Because that's what's going to result eventually in the cardiovascular disease events. And so when we summarize longitudinal studies, as you can see here, the duration of follow-up can be variable from 5 to 35 years, but there's robust data for type 2 diabetes, and there are the relative risks, which I hadn't included earlier, and both for type 2 diabetes and hypertension. And then the mean differences for the cholesterol levels are smaller. And interestingly, there are studies that show that family members of patients with PCOS also have increased metabolic risk, reflected by hypertension, dyslipidemia, and then the composite metabolic syndrome as well. This doesn't come as a surprise because, with the GWAS studies that have looked at genetic associations with PCOS, so on the top here you can see what's called as a Manhattan plot. And above the green lines are some of the genes that have stood out in the different GWAS studies as related and correlating with PCOS. And when a regression analysis was performed, as you can see in the bottom here, a number of the risk factors that we've talked about, BMI, fasting insulin level, type 2 diabetes, triglyceride levels, have significant correlations and genetic correlations with PCOS status, indicating that the genetic architecture and biology for these conditions might be shared. So what happens during pregnancy? Women with PCOS during pregnancy have a higher risk for pregnancy-induced hypertension, preeclampsia, gestational diabetes, and preterm delivery. And in the postpartum period, we have shown that they have a higher risk of postpartum preeclampsia, postpartum eclampsia, and hypertensive heart disease. So collectively, a number of these factors, like preeclampsia and gestational diabetes, increase the risk of long-term type 2 diabetes and cardiovascular disease, and hence become really relevant for this talk, because at different stages during the reproductive lifespan, women with PCOS are indicating that they are a high-risk population. So here's a summary of what we've spoken about till now, that women with PCOS combined with the insulin resistance, hyperandrogenemia, and obesity have evidence of traditional cardiovascular risk factors. And in the next half of the talk, I'm going to show you the evidence for premature atherosclerosis as well as the coronary artery disease. And there are a number of ways in which one can measure subclinical atherosclerosis. So what I'm referring to is these patients have not had the heart attack or the stroke. However, there are tests that can tell us along the spectrum, is there change occurring within their blood vessels that would indicate that they are at a higher risk. And so as you can see in this diagram here is the clogged artery. And that's when there would be a clinical manifestation of the thrombus rupturing and myocardial infarction. We are looking for tests that will be able to pick up the disease within this early stage. And I have listed here the 5 different tests that have been conducted within the PCOS population. And we'll go over each of these and the data that's currently available for each of these test modalities. So the flow-mediated dilatation is one of the ways that one can measure changes in the ability of the vessels to dilate and contract, their flexibility in a way, and it correlates with cardiovascular disease. So here is a meta-analysis conducted in 2013 with 908 patients, 21 studies. So you can see they have small patients within each study, but age and BMI match. We find that the mean flow-mediated dilatation is lower in women with PCOS. And when they conducted a sub-analysis with the Rotterdam criteria, this still remained at about a 4% decrease, which is substantial because these are young reproductive age women, and even these smaller changes would not bode well for long-term prediction. There have been a few studies published since 2013 and since this meta-analysis that show mixed results, primarily indicating that obesity might be driving a lot of these changes. Another method is known as arterial stiffness, and this is measured by checking the pulse wave velocity. And in the general population, pulse wave velocity correlates both with age as well as obesity. We have mixed results in PCOS adults. Interestingly, there are more studies in adolescents because this is a non-invasive and an easier test to conduct. And again, what they're showing, primarily these findings are driven by obesity. Only one study showed a higher risk when they measured the arterial stiffness index in adolescents. And there's really no data with PCOS women in the menopause, but there are menopausal studies where authors have looked at the correlation with free androgen index and with pulse wave velocity. So very indirect evidence with this particular way of measuring subclinical atherosclerosis. We have a lot more data with carotid artery intima media thickness, and this is measured right here in the neck with ultrasound. And again, we have a meta-analysis here from 2012 with about 1,123 women with PCOS, so much higher numbers. And what they do show is that the intima media is thickened in women with PCOS compared to controls. And in fact, there are data that show that with every unit change in the carotid intima media thickness, this can predict future cardiovascular disease. Recent studies again support these findings in the direction that these women with PCOS have increased thickness. They have looked at correlation with BMI, and like most of these markers, there is a correlation with BMI. There are studies that actually show no difference with the hyperandrogenic and non-hyperandrogenic phenotype, and then very few studies in the menopausal period. The epicardial adipose tissue thickness is a relatively novel way of looking at fatty tissue that's been deposited around the heart. It can be done in a non-invasive way using echocardiography, and is another marker instead of visceral adiposity to look at epicardial adiposity. And again, just 2 studies in the literature, so not much data with this modality. And then finally moving on to coronary artery calcium scores, which are used a lot more for risk stratification as well as for therapy by cardiologists. And they give us evidence of calcification, as you can see on the CT scans here, and the presence of calcification within the plaques. And so the measures are given in the form of a score, a coronary artery calcium score. And what these studies here in women with PCOS show us is that the coronary artery calcium scores here in women with PCOS in these 4 studies that I have bolded as compared to the controls. The first one here came from our group that showed in BMI matched patients a relative risk of, or an odds ratio of 5.5. More recently in the diabetes prevention trial, which has tracked women over 10 years, and they included more than 2,000 women, but these are all comers, not with PCOS, they did not find a correlation between irregular menses and the calcium scores, or between a free androgen index and the calcium scores, sort of using surrogate markers for the diagnosis of PCOS. And the importance of finding any calcium in women with PCOS is because these studies have all been done in young women. And so in the young population, as you see here, the green line is the 90th percentile, which indicates that these women are at the top percentile for the calcium score that we would see in a young population. And if you already start with calcium deposition at a younger age, the trajectory is likely to be high, and hence that puts you into a high-risk category. So let's finally shift towards having seen an increased prevalence of biomarkers. We know there's increased evidence of subclinical disease. Do we really have data that shows that women with PCOS are suffering from cardiovascular events? And by that I mean things like stroke, myocardial infarction, ischemic heart disease. And here is the data from a meta-analysis looking at outcomes of stroke, 1.96 for the odds ratio. And let me just start with the caveats here, that the diagnosis in all of these studies may not be uniform, as we recognize the Rotterdam criteria. The study sizes are very variable. Most of these data look at reproductive age women, fewer for menopause. The follow-up duration is variable, but a lot of studies are from population-based studies and from countries that have large data sets with patients being tracked through these national health registries. And then we always have to ask about the role of BMI. What I have here is an umbrella meta-analysis, the references down there, that was conducted, putting together 3 meta-analyses that have been published, and they still show a sustained increase in the risk of stroke in women with PCOS. When we look at the risk of myocardial infarction, it's increased 2.57. and ischemic heart disease 2.7, and the umbrella meta-analyses, even though there was a slight decrease, still persistent increase at 1.4. What these studies do not show is an increase in the risk of death associated and related with cardiovascular disease. And this might be, again, shorter durations of follow-through might be reflecting this, maybe the reason for this finding, or also because of the fewer numbers, where we actually need to have larger numbers with mortality to be able to find significant differences. So having completed that part of the talk, let's now briefly talk about how are we screening our patients for primary prevention of cardiovascular disease, knowing this data. So critical that we weigh our patients at each visit and track changes in their weight so we can counsel them and intervene appropriately. Important to perform glucose screening at some regular frequency, either in the form of fasting glucose or hemoglobin A1C. We've come away now from recommending an OGTT for every patient. But as you know, that's the one test that really will reveal the impaired glucose tolerance, and hence is still an important way of picking up patients who may have impaired glucose tolerance and may not be reflected on a fasting glucose level. And we do recommend performing the OGTT in pregnancy a little earlier than the standard recommendations. Given the high risk of hypertension, important to check blood pressure at each visit, and also perform the lipid screening, because there will be patients that have the elevated triglycerides or LDL that is clinically significant and you can intervene. I didn't have as much time to talk about obstructive sleep apnea or fatty liver disease, which are now being associated with PCOS as well. I want to point out that both the American Diabetes Association, it considers PCOS as a risk factor for gestational diabetes, and then the ACC-AHA guidelines, so this is the American College of Cardiology and the American Heart Association, in their most recent 2019 guidelines, they included a history of preeclampsia as a risk-enhancing factor, a history of metabolic syndrome as a risk-enhancing factor, and elevated CRP. So a number of these are already risk factors that I have reviewed with you for PCOS patients, and hence these patients, would be at increased risk for heart disease. And the data for preeclampsia comes from a number of studies that are showing almost a 3 to 4-fold increased risk for heart failure in women who have had a history of preeclampsia. So let me conclude by this schema, because we didn't have time to talk about actual treatments. We talked about screening for cardiovascular disease, and a risk assessment can take different forms. In the US here, we use the ASCVD risk score, which is a nice app that we can download and give patients their 10-year risk. And in some cases, even use coronary artery calcium scores to enhance that risk assessment. Healthy lifestyle is critical for all patients with PCOS, and counseling about it becomes important. We have used insulin sensitizers very liberally in our field. Metformin as recommended in women who are overweight and obese, and the GLP-1 agonists seem to be playing, or at least demonstrating, extremely good results in terms of weight management and hence improvement in the cardiometabolic biomarkers that I talked about. Statin therapy not used as commonly in the reproductive age group, but really has an important role in prevention of long-term cardiovascular disease. So I think there will be more to come. I'm going to conclude with that. I do want to again say a big thank you for inviting me today. And I want to acknowledge a lot of my collaborators, both clinical collaborators at the Penn PCOS Center in Philadelphia, as well as my research collaborators that are not just local to Pennsylvania and the US, but also a number of international collaborators through the AE-PCOS Society. So thank you very much.
Thank you very much for the presentations, excellent presentations. I'd like to invite all of you to answer the questions And we have a first question here, maybe to Selma. The question is, just a moment, sorry. For a girl with 16 years old in amenorrhea, normal androgens, with normal karyotype, is the induction of menses with oral contraceptives a good choice? And how to exclude PCOS in this case?
That's a wonderful, common clinical scenario that we have, and I would counter with more questions. Is this primary or secondary amenorrhea? And by normal androgens, what androgens have been looked at? We talked a lot about congenital adrenal hyperplasia, non-classic, having symptoms similar to PCOS, so that needs to be excluded. Again, in the adolescent population, at least in the United States, one worries about undiagnosed pregnancy. Again, excluding other causes, thyroid functions, hyperprolactinemia. Is there an eating disorder? What about pubertal staging? Has puberty progressed normally up until this point? So I think I really have more questions. If it's the ultrasound is normal, but if it's primary amenorrhea, I might try progesterone withdrawal first. If everything else is excluded, and we're thinking this young lady might be at risk for PCOS, I think it's fine to treat her with combined oral contraceptives, but there needs to be a plan for follow-up. And follow-up to go to Dr. Hoger, Dr. Dokras, and Dr. Vanke over time, because at some point patients age out of the pediatric endocrinologist. So I think this is a very common clinical scenario, and just have a few more questions that I think would benefit from being answered by the clinician. Thank you for the question.
So there's another question. I think we'll direct it to Dr. Dokras and possibly Dr. Vanke as well. Is it possible to determine whether the improvement of clinical features in women with PCOS through time is the natural evolution of this condition, or is it an effect of long-term treatment? Your thoughts?
I think that's a very good question, and based on our current data, when you look at longitudinal tracking in patients with PCOS, there is evidence that those who are not on treatment as well, so if you're not taking the birth control pills, there is an improvement in men's. There's a decrease in antral follicle counts and AMH levels that have been demonstrated longitudinally, and a corresponding decrease in ovarian volume. So my impression is that this is an improvement given an ovarian etiology, that it's occurring over time, irrespective of whether these patients in their reproductive years have been exposed to metformin or birth control pills. But I think that's where it's a very good question, which is being presented, that is the trajectory different for those who might have had some intervention versus those who have not been managed as actively. But I can tell you from my personal clinical experience, the patients who've been put on birth control pills sort of this longitudinally, and you say, let's give a holiday, let's stop it in your mid-30s or 40s, let's reevaluate where your menses are. The vast majority have now started cycling more regularly. But I really haven't seen any graphs or tables that show exposure and no exposure to OCPs versus metformin, and are those trajectories any different?
Thank you.
Maybe a question to Dr. Exter Vanki. Could you summarize what are the current recommendations for women with PCOS before and during pregnancy regarding risk for gestational diabetes and premature deliveries?
I'm sorry, could you please repeat it? What was the question? What are the risk factors or the workup? I couldn't hear it.
No problem. Could you summarize what are the current recommendations for women with PCOS regarding risk of gestational diabetes and premature deliveries? Patients with PCOS, what do you do?
Yes. Well, according to the international PCOS guidelines, there are some recommendations to have of course, a general obstetric background, history, a general medical history, also have blood pressure measured, HbA1c measured before pregnancy if they plan their pregnancy. Weight reduction is recommended. However, we do not have very good data on what weight reduction just before pregnancy really means for the pregnancy outcome. We recommend it, but we are not sure whether it works or not. Generally, of course, these general recommendations: stop smoking, more physical activity, healthy eating habits, and when they become pregnant, we recommend screening both in first and in second trimester of pregnancy for gestational diabetes, and of course regular blood pressure measuring and checking proteinuria during pregnancy at each visit to catch hypertensive disease in pregnancy. These are the general recommendations from the international guidelines. There are no specific recommendations to screen for risk for late miscarriages or preterm birth, because this is a very difficult field in obstetrics. We have no good screening tools for that. But of course, those who had preterm deliveries and miscarriages, they are at high risks.
Okay, a question for Dr. Dokras. Non-fasting triglycerides and ApoB have been suggested as early CVD risk markers. Have these been used in studies?
Yes, yeah. So there's a lot of data in adolescents, reproductive age women with PCOS, looking at all the different elements of a lipid profile, and so the triglyceride and the triglyceride HDL ratio was one of the earlier ones that had come up again as an indicator. Over time, we replaced that triglyceride to HDL and started looking at the apolipoproteins. And so there is some data for the apolipoprotein B levels tracking. It's not as commonly used in what we are recommending, as you saw in the schema from the International PCOS guidelines, as a screening tool. I don't think it's really even come into the screening tools for internists or cardiologists to that extent. So primarily still either a research tool or gets incorporated at a second level. So if you're high risk because of your family history, your own factors, and one is trying to determine should we initiate statins, I think that's the time when the internists and cardiologists bring in the apolipoprotein levels more so. So we are looking at our international PCOS guidelines again. It's been 5 years. I'm not entirely sure there's enough data that we might incorporate ApoB, but triglycerides I think will remain, and there is newer data that also shows, just like LDL-C being an independent predictor, I think there is newer data with ApoC and triglycerides tracking with cardiovascular events. So that'll definitely remain in our screening strategy.
Great, thank you very much. Okay, there's a question for Dr. Venki. The use of metformin only during the first trimester could be an idea to prevent the negative effects on the newborns. Is that a possibility, in your opinion, Dr. Venki? I think you're on mute.
That's a good question. Let me say like this, that if the patient is on metformin and become pregnant, then they can go on with metformin during the first trimester and then stop at the beginning of the second trimester. We have no indications of negative effect of metformin during the first semester. Whether we have positive effects, it might be, but I haven't seen convincing data on it. And I recommend my patients, as it is now, to stop with metformin at the end of the first trimester, except for a very small group of patients who had late miscarriage, who had very early or early preterm birth. And if I inform her about our data, about the potential risk of having a child who has increased risk for overweight, and if she agrees, I let her go on with metformin through the entire pregnancy. That's my policy on this, but there are no guidelines actually on how to deal with metformin, except that metformin is not generally recommended through pregnancy in women with PCOS.
Great, thank you.
Maybe you can have another question to Dr. Selma. For a young girl with PCOS or at risk for PCOS that cannot use or don't want to use combined oral contraceptives and have irregular menses and hirsutism, what would be your choice?
So I often use transdermal estrogen and cycle with transdermal estrogen and oral progesterone. I had a few patients at risk for PCOS and carry, factor V Leiden or some other contraindication to oral estrogens. And for those folks, occasionally we'll use Mirena IUD and spironolactone. So I think it involves consideration of any other risk factors and a discussion with the young lady and her family about what would be appropriate. I generally do, in my population, don't use spironolactone without very effective birth control.
So I have a question for Dr. Wichtel, just to kind of give your thoughts on if you have a young patient who you are classifying as at risk for PCOS, too young to make the diagnosis formally, what is your general policy? When do you reassess the patient, and what kind of advice do you give?
So we talk about being at risk. Many of these young ladies benefit from being on combined oral contraceptives, and then they're going off to college where they need combined oral contraceptives for other reasons as well. So we reassess largely to look at and provide counseling about weight and healthy lifestyle, because that's so important, and generally try to follow and eventually refer them to an adult endocrinologist or reproductive endocrinologist while they're still on oral contraceptives and eventually be reevaluated. But I want to just shout out to Dr. Dokras, who provided me with the inspiration for the 3 blind men, because we don't want our patients to be in the situation where they leave the pediatric endocrinologist or the pediatrician, wander around through college, and end up at the reproductive endocrinologist with infertility. So I think it's important to explain to the young lady, and mostly her mother, the importance of adequate follow-up through college with transition to an appropriate adult care provider.
Great. Thanks.
Maybe for another question to Dr. Dokras, in patients with PCOS after menopause, do you perform some special evaluation before planning a hormone therapy for menopause in these patients regarding cardiovascular risks? Be more aggressive or not? You are mute.
Sorry, these are good questions, and again, where we have limited data. So if you were not taking the hormone replacement therapy into consideration as yet, but you just wanted to say, what are we doing for this population around the menopause, then it would be the same as anybody else with respect to tracking their menstrual history, any menopausal symptoms that are arising at this time period. There could still be hirsutism because, as you know, even though the androgens drop, the thicker, darker, coarser hair that's undergone the permanent change remains unless they do laser or electrolysis to remove it more permanently. So there are some of those discussions that do continue into this time period. And currently we don't understand whether we are recommending every 5-year evaluation of cardiometabolic risk or more frequently, because we don't have those longitudinal studies. So one would just go with their prior evaluation, and if they are pre-diabetic, of course you're following them more frequently. If the numbers are more normal, then even an every 3 to 5 year evaluation is okay for cardiometabolic metabolic risk factors. Now, for the hormone replacement therapy part, really the current guidelines suggest that if your patients have, it's more symptomatic rather than preventive, right? So if there's hot flashes, there's vaginal dryness, there's symptomatic management. And then the question becomes, if you're going to replace estrogens in that time period in a patient who has higher cardiometabolic risk, how is that going to play in? The replacement that we give for HRT is much, much lower than birth control pills. And so again, it's a little bit of a discussion and weighing the risk and benefit. I think a short duration of estrogen-based hormone replacement therapy may be safe as a personalized approach, or there are neo medications on the market for treatment of, say, hot flashes now, which are non-hormonal. So I don't think one size fits all, and it'll have to be a personalized approach to say, what is the perimenopausal, menopausal symptom I'm trying to treat, and how does that fit in with this particular patient? Does she have obesity? Are the triglycerides up? And again, keeping in mind, if these are short-term therapies with the lowest dose of estrogens, we might be okay for short periods of time.
Thank you. So I think we need to close this section. We are on time. I don't know if would you like to say any comment in addition to what we thought just now? So Kathy, would you like to close the session?
Okay, well, thank you very much. First of all, to our speakers, Dr. Wichtel, Dr. Benke, and Dr. Dokras, taking us through the life cycle of PCOS in this session. Extremely beneficial, I think, to kind of put all of these things in perspective. Thank you again for allowing the AEPCOS to have a session at the Endo-Feminine Conference, and welcome to all our new members who've joined AEPCOS, and to those who are our current members. And thank you again for your attention.
Thank you, everyone.
Yeah, thank you for including us. Thanks.
Bye-bye.
Bye. Thank
Bye-bye.
you. Bye.